We'll now move on to our next session for the talk titled Structural Competency in Medical Education by Dr. Rakhal Gaitonde, who will be joining us online, and I invite Dr. Ansuk Pulimo to moderate the session.
Thank you to the Department of Medicine for giving me an opportunity to be a part of this meeting. I'm here to introduce Dr. Rakhal. I first met Rakhal at a workshop in 2010, and I was really impressed because he told us stories of his experiences in dealing with inequities in first in an Anganwadi, and then in a patient with tuberculosis who could not afford food. So, chose actually not to take anti-TB drugs than to face the problem of hunger. So those stories still stick with me. And I think ever since he finished his postgraduate degree in CMC-MAC in community medicine and went on to various jobs, I think he's consistently worked on inequities. He's published books. He's edited a book, written several book chapters, and all his publications are on varied aspects of inequalities or unfairness in healthcare. And currently he works as professor in the Sri Chitra Tirunal Institute of Medical Sciences and Technology, but also worked at the Foundation for Research in Community Health in Pune, Society for Community Health Awareness Research and Action in Bangalore, and at the Center for Technology and Policy at the IIT Chennai. So I'm sure we're all excited to hear Rakhal. He's going to be speaking to us on structural competency in medical education. Rakhal, we're sorry you could not be here in person, but we look forward to hearing from you.
Good morning to all of you. I am recording this in the backdrop of terrible violence being committed to lakhs of people all around the world, whether it is Gaza, Manipur, Ukraine, the Democratic Republic of Congo, Myanmar, or other lesser known but equally horrific theaters of war and conflict. This immense suffering is superimposed on crushing structural violence. For example, one person dies of tuberculosis every minute in this country, despite us having very effective treatment for the disease. And lakhs undergo daily discrimination in the name of sexual identity, caste, race, or religion. Both this continuing physical and structural violence reflect the hypocrisy of those in power and the absolute lack of commitment to health. It is in this depressing backdrop that I reflect on the clinic and the classroom. I reflect as someone who has immensely enjoyed and benefited from the clinic, but having given up the clinic in order to pursue public health. My wake-up call, as it were, was a patient with tuberculosis who I diagnosed and got cured after anti-tuberculosis treatment. He came back with a recurrence many months later. And looking at my naively surprised face, he said, "Doctor, you only cured my disease, but I went straight back to the place and the context which gave me the disease in the first place, and nothing there had changed. Why are you surprised that I got this disease again?" The immediate response is that these are social reasons and that these are separate from the clinic, and there is very little that we sitting in the clinic as doctors can do about these larger social issues. I, on the other hand, argue that diagnosis is but a part of the clinical journey. Healing is its end. A physician's responsibility thus continues up to the point of healing. Of course, some aspects of the journey may be more or less under control of the health system, but that does not mean we can ignore them. And for this, I argue that we need to blur the boundaries of the clinic. And by extension, we need to blur the boundaries of the classroom. Assuming that health and disease emerge from gene-environment interactions, Nancy Krieger helpfully points out that this interaction, in fact, is mediated through bodies. And in societies, all bodies are not treated equally. Male bodies are treated differently from female bodies. And both male and female bodies are treated differently from trans bodies. Dalit bodies, Adivasi bodies, aged bodies, differentially abled bodies, rich bodies, poor bodies are all treated differently by society. This leads to a differential exposure to risk, a differential vulnerability to disease, and the differential consequences of disease. The key issue then is how do we apply biomedical knowledge in this socially structured environment? And equally, how do we advocate for changes that enable the effectiveness of this scientific knowledge, even as we demand the creation for more relevant knowledge? And for this, I argue, we need to rethink the classroom. We need to see the classroom as an extension of the world we want to build. The process of transforming our present classrooms, warts and all, into democratic, just, and inclusive spaces that truly foster health in the truest sense of the word is the only way we can do this. And for this, I argue, we need to look at least 3 different dimensions of the issue. We need to look at the content of our teaching. We need to look at the form and the design of our pedagogy. And we need to look at the way we can foster an inclusive and caring space in the classroom. The issue regarding content was brought to me by my Dalit students, who pointed out that many of my examples were actually alienating to them. It's a bit like how, our patients who are struggling to put food on the table, who are forever guilty when they see their children going home, going to sleep hungry. When we talk to them about the importance of having a diet with 5 servings of fruit and vegetables, can we imagine the type of alienation our advice will be giving them, will be causing them? Or it's like how manual scavengers or daily wage laborers would feel when we explain to them the importance of regular exercise to reduce their risk of NCD. The question thus is not about what evidence there is for a given condition, but how relevant is that evidence in the particular context in which it is being applied? And equally, how do we create circumstances that enable the application of this evidence or the conversion of this evidence into tangible benefits for those who are able to follow it? How often do we partner with patients to set this research agenda? How often do we partner or request patients to audit the medical curriculum? These, to me, are critical questions that we need to reflect on when we are reflecting on the content of our teaching. When it comes to the form of teaching, I argue that more than just imparting knowledge to students, which probably students have access to much more than we have, the importance is of students experiencing the context, the vulnerabilities, and the marginalizations that their patients embody. And for this, can we move to learning methods that are drawn from social movements that enable experiential learning? And what I'm talking about are simulation games, role plays, immersive encounters, field visits, and so on, that enable openness, humility, and a multisensorial learning experience which is not possible by just sitting in a classroom looking at a PowerPoint presentation. The third aspect of addressing structural competencies is the struggle to transform the classroom into a caring and inclusive space. Very much like the space we would all like to have in the world, which would foster then health. How many of our students have mental health problems, and how are they dealing with it? How many of our students are victims of sexual harassment and abuse, and how are they dealing with it? How many students face caste discrimination on a daily basis, and how are they dealing with it? How can we make the classroom and the pedagogy that we bring to the classroom more supportive of their healing, of their flourishing? That, to me, is a real challenge and a question for us teachers to reflect on. In conclusion, I argue that we need to struggle with our students to create more democratic, just, and inclusive spaces here and now. The effort, the struggle is at the core of building a truly liberating curriculum and pedagogy. And from that struggle will emerge the education that will support our march towards health for all. Thank you very much for your patience.
Do we have any questions from the audience? Rakhal, I have one question for you. So the National Medical Commission has a fixed competency-based curriculum that's so vast that teachers are not even able to cover the existing curriculum. So how do you think we can approach this problem of trying to bring in all these other aspects of medical education into that? Do you say we should enter it into the curriculum, or and with the given number of medical colleges in our country, where do we start? How do we start? What are your suggestions?
Sure. Thanks very much, Dr. Ansu. I think one of the core points that I have discovered in my own journey as a teacher, which I tried to share in this talk, was that we need to begin to think beyond content. That pedagogy, the form of the way we deliver, the relationships we build, the space we co-create are probably as important or even more important than content. Today, given the way in which content is available at the tip of your fingers and probably much better navigated by our students than by us, to me, the challenge is about creating the space, and that is my point. So therefore, my answer would be, to your specific question, I haven't thought about it in very clear ways. But I think the point would be about how to deliver this, content in a democratic in a democratic way. How do we deliver the curriculum, realizing that students in our classrooms would have undergone trauma, would have undergone discrimination, are undergoing discrimination, and struggling with probably depression on a daily basis. To me, this collective struggle of creating spaces, creating methods, is an experience of creating the better world that we have, that we want. And so to me, I think the focus is really on the methods and the pedagogy rather than on the content.
Yeah, that's really true. And I think change happens at the individual level. So when a teacher relates to a student, when the student relates to a teacher, they learn. And definitely the change happens there. But, how do we go about this? In such a large country with so many institutes, I think many institutes where students don't even see many patients. And I think there are two problems. One is a student related problem, and the other is their attitude to people. So I think the student related problem, I think, may be easier to bring into effect, because if you insist that all colleges have a counselor for the students and provide documentation that they are, doing certain things to help students, I think that can actually be solved by some kind of regulations. Maybe, somebody should look into that and bring that. I think when you come to accreditation with the NAC, you do have student counseling and all that coming in, but with the NMC, it's not so strict. Maybe that's something that, we can advocate. So that is the mental health of individuals, students. That is something that can be done.
Yeah, but just to sort of build on what I already said, I think there are two other aspects. So, for example, even within I think the latest NMC guidelines, there's this whole thing about adopting families, for example, as a way forward, and there's been a lot of discussion about that. So I think there are possible strategies like that encourage more of experiential learning. I think that we need to really look at. The other is to see is to relook at the content itself. Treatment of non-communicable diseases. The most we talk about are as we call it, but where in our content to, for example, more innovative methods of enhancing adherence among marginalized groups. For example, the patient support groups that have been innovated and have been used, for example, in Jan Swasthya Sahyog in Chhattisgarh, which showed an improvement, in adherence from 24% to almost 90% among their chronic disease patients. Now, where in the curriculum can we fit in such innovations that are community-based, that are participatory in nature, that force doctors to think beyond the clinic? So it's as much as about delivering the content in ways that are experiential, as much as auditing the content itself to see whether the content of our teaching is actually accurately reflecting the sort of innovations that are happening and that are continually happening among and with marginalized and vulnerable groups.
Thanks, Rakhal. There are a few questions from the audience. In the era of preparing for the NEET PG exam, even from first year, how do we inspire students to look at real world problems?
Yeah, so I don't think that's an easy question or an I mean, there are no easy answers in other way, but the critical point and where I learned, all of, and where I derived most of my passion were from the role models that we had. And I think it is absolutely essential for faculty, for teachers to realize just as values are caught in families or in other spaces of socialization, role models and being reflective, being open, being humble, as as faculty and teachers is just so important. Two, I think there is, if we are able to in our institutions at least move towards creating spaces of discussion. I think rather than this monotonous sort of, rote learning that now seems to be the sort of way to go. NEET is a good example, but just creating spaces and allowing students to innovate. I mean, students to choose their own, questions, and it seems messy, but the more these spaces for, self reflection, the more the spaces we create for debate. To me, I think, we will be moving towards, possibly better learning and education. This isn't a direct answer to your question, but just sort of the direction in which I would think. Yeah.
There's another question being asked on whether this kind of material should be introduced in the +2 syllabus and even actually ask questions in the NEET, related to this topic.
Well, I think that the school is the place to start this, and in fact, at least the NCERT syllabus that my son went through, where in his third standard or fourth standard maths, he had to clock the time that his father spent in the kitchen and the time his mother spent in the kitchen under the the lesson on reading and learning about time, was a very important lesson in gender. And I think these sort of innovations are already there in many curriculum. And the NCERT, I'm mostly familiar with the NCERT curriculum, and throughout school curriculum, we have these wonderful methods of raising awareness. But again, with the type of pressures that we as a generation are putting on younger people, the type of opportunities that are available, it is, I think, a very difficult ask. But I think the issue is urgent enough that many more of us need to start thinking about it, raising our voices.
There's another question on how important it is to have underrepresented groups being represented among faculty. Should you have reservation?
Absolutely. I believe very strongly in the need for diversity. I speak, being a member of an institution that had this discussion. We called ourselves Institute of National Importance, and for many years argued that because it was national importance, we were above reservation. I'm very happy that our institution has, over the last few years, brought in the reservation policy for all levels of staff. I think this is absolutely important, because the insights, the perspectives, and the framing of problems that happen when we have a diverse set of faculty cannot be in any way replaced by a homogeneous group, however sensitive they are. And two, we need to take into account that even as faculty we are discussing, the student body is becoming more diverse thanks to the democratic pressure that has taken place. And to support a diverse student body, we need a diverse faculty body. So to me, there is absolutely no question about the importance of having diversity among faculty. And I am, and many of us are acutely aware that in the institutional space we ourselves occupy, there isn't that diversity. And I think we need to reflect on that. We need to reflect on how we as a collective privileged class, caste, and gender can seed spaces in many ways. At present, it's merely rhetoric from me, but I think we need to reflect more openly and honestly about how we can bring this about very soon.
Okay, the next question is, sorry, do we have time for another? One more question. Okay, so basically they talked about, there's a question about teacher training for these aspects of creating safe spaces and learning, but I think we don't have time for that. There's another question about, there's one interesting question. How would you describe the pedagogy of this conference that we're a part of? Does a conference of doctors satisfy the rethinking of equity?
I don't think, frankly, that there can be one perfect conference and one perfect design that's going to answer equity. I think the more we discuss equity in a number of different forums, the more the project of equity is going to move forward. To me, I am extremely happy that a medical conference is talking about equity. Now, is this the only way we can talk about equity? No. Is this the best way we can talk about equity? No. Am I happy? Absolutely. Because people are talking about equity.
Okay, great answer. And thanks for all the interaction we had with you, Rakhal, and for your talk. Thank you so much.
Thank you, Dr. Rakhal and Dr. Ansu, for that discussion.